And thank you very much, everyone, for logging in this evening to our session. My name is Ken, and I'll be your facilitator this evening, together with my colleagues, Imelda and Emily. Today's session is our November edition of TECLA, which is Tele-Education for Clinicians and Leaders in Africa. Our topic this evening is pharmacological management of diabetes. We work together with our partners, who are the Hospital Pharmacists Association of Kenya, HOPAC, MDOC, which is a social enterprise from Nigeria, the Rural Private Hospitals Association of Kenya, RUFA, Ashoka, Boehringer Ingelheim, and we are the CDMS hosting this today, and CDMS is Chronic Drugs Medical Scheme. TECLA has hubs in Africa, 2 hubs, and one is MDOC of Nigeria, and CDMS is based in Kenya. It is the intention that these will increase right across the continent in the future. Our sessions are based on the need for knowledge sharing and also sharing of best practices, so as to reach as many health practitioners as possible, and to be able to then relate these by applying this knowledge to the patients that they serve. We also work with hub experts, some of whose pictures are on your screen right now. Please take note that Project TECLA Africa leverages the ECO model. What this means is that we will be collecting registration details, or your participation details, any questions and answers. And these are for the purposes of improving our programs. Your data may be taken, but will be kept confidential and handled by authorized personnel only. These may be used for reports, maps, surveys, quality assurance, and also in order to help us to inform new initiatives. This session will be recorded, and like I said earlier, we will be sharing a PDF version of the slides using the email address with which you registered after the session. Can I request that if your bandwidth allows you, have your camera on and do not unmute. If you need to say anything, please use the chat function, because the chat master will be there ready to pick any questions, and these will be forwarded to the speaker, or if it is something that requires to be responded to by any of my colleagues, this will be sent to the right person, and hopefully by the end of the session, your question will have been answered. Just in case you need any tech support, the details of my colleagues are on the screen, their phone numbers and names. So you can reach either Habil, Robert, Achieng, Imelda, or Emily. Our agenda this evening is on the screen. And as you can see, we should be wrapping up by 8:30, which is in 1.5 hours. So at this point, please allow me to invite our host, the CEO of CDMS, Sam Agutu.
Good evening, everyone, and welcome to our session today. We are grateful that you are able to make it and to log in time. CDMS is a Kenyan social enterprise. and with the mission of improving health outcomes using digital solutions and strategic partnerships. We have two pillars on which our business stands on. The first one is Tekla. This is an education platform that is presenting these EME sessions. The second one is Tibanet, which is an e-commerce platform for group purchasing targeting small hospitals. We also conduct patient safety programs and are currently working with several public referral hospitals. Once again, thank you very much for joining and enjoy the evening. Back to you, Ken.
Thank you very much, Sam. You can also reach us on our social media handles, as I've said before, and those addresses and the handles are on the screen now. So you can join us and follow us on Facebook, on Twitter, on Instagram, on LinkedIn, or YouTube. At this point, we will have a precision quiz. The purpose of this quiz is to test our understanding before the didactic speaker comes on. I request that everyone attempts this quiz. It will be posted again after the session just to test our learning. So can I ask Habil to please post the quiz and let's get going.
I see a few people have started attempting the quiz. Please, I'd like to encourage everybody to give it a try.
Yes, I can see many of us have started the quiz. Let's have a few more participating. We'd like to encourage everyone to take part in this quiz just to test our knowledge of this topic before the didactic speaker comes on.
How are you? How are you?
We have 90 seconds to go. I'd like to appreciate those who have attempted the quiz. Can we have a few more people, please? Another 20 seconds and we're good to go. You still have a minute or so if you haven't attempted the quiz. All right. We can end the poll. Thank you very much for those who have attempted the quiz. Like I said, later on after the session, we will post the same quiz again to test our learning this evening. It is now my honor to introduce our speaker this evening. Our speaker is Dr. Robert Mwangi, who is a graduate of the University of Nairobi. He also holds a Master of Pharmacy degree in clinical pharmacy from the same university. He has extensive experience and has served in various hospitals, including the Nyeri County Referral Hospital, and currently practices at the Kiambu Level 5 Hospital in Kiambu County in Kenya. Dr. Mwangi will be presenting a case and also be the didactic speaker for the evening. So join me in welcoming Dr. Robert Mwangi. Dr. Mwangi. I don't know if it's just me. I can't hear Dr. Mwangi.
Hello, how to join? Okay. Good evening.
Good evening.
Yes, hope you can hear me now.
Yes, I can hear you. We can hear you.
Now.
Yeah,
Yes, we can hear you.
Yes, the slide.
Not yet.
Sorry.
We can see your slides, Dr. Maybe just put it on presentation mode. Thank you. You may proceed, Dr. Mwangi.
Hi, Dr. Mwangi.
Okay, let me just check with Dr. Mwangi.
Yes, please. Sorry for that. So we'll start with the case presentation. So as I had said, we have patients who will come with various conditions, and they'll present with one or two conditions which specifically you may not, once in a while, you may not relate diabetes. So my case here is for a 72-year-old male who comes with a chief complaint of right lower limb swelling. That is for 4 days, polyuria and polydipsia for 2 weeks. HPI, that is the history of the presenting illness. The swelling was gradually in onset, associated with pain and progressively increasing with no history of trauma. So this is a patient who came to hospital after being referred from another facility. So he had visited that facility where antibiotics were given. He cannot recall which ones they were, but he remembers that fluids were administered to him. The patient was referred now to this facility for further review and management, with the legs still swollen and painful. First medical history. This is a patient who is known as having diabetes for the last 3 years. He's been on treatment with metformin, but he says he hasn't taken the drug for the whole of this year. And this is his first admission. On the family social history, the patient is married with 6 children who are alive and well. He has a mother and a sister who are diabetic. Now, this is important information, as we will see. Social economic history. The patient is a farmer. He's a non-alcoholic who takes Moratina and keg, and is a smoker for 25 years. On physical examination, we find that the patient has a blood pressure of 124/86, a pulse rate of 86, and a respiratory rate of 23, and SpO2 of 92%. The system that is of interest here is the musculoskeletal system because it presents with pain. And we find that the right leg is swollen globally up to the knee. And he has also pitting edema. Other systems are unremarkable. On further investigations, we find that the patient has a normal X-ray. Diagram shows the patient has an infection. On urinalysis, we find that the patient has a high glucose of 3+ with ketones. So the question is, how will you handle this, or what do you think the patient will be having? So the impression made is DKA, that is diabetic acidosis in a diabetic patient who is not compliant to medication, who also has cellulitis of the right lower limb. The plan here was to provide fluids, and that is basically the DKA protocol that is initiated, a provision of insulin, an antibiotic, and an analgesic. So basically, this is the kind of thing that we see. The patient had come the day before, and we found that the pressures are not very good. But with time, we see improvement because the random blood sugar, fasting blood sugar decreases from 21 to 10. After 2 or 3 other days, we find that there's a resolution of the symptoms. So as I was saying, this is a case that we see, or this is the kind of presentation that we have, because we have patients who are walking around who may not be on treatment or who are on treatment. Statistics tell us that we have around 2/3 of people with diabetes do not know they have diabetes. And it provides a challenge to healthcare providers to provide care anytime they meet a patient. So that is the presentation for our patient. I want you to look around to think about it and look at the points at which we can have interventions and and the things that point to problems that, as in the things that show what kind of treatment a patient can be given after we have gone through the pharmacological management. So we'll move on to look at how drugs are used in the management of diabetes. Now, pharmacological management of diabetes. As we know, diabetes comes because of sugars not being well controlled. And it means also that the bedrock of treatment, or the most important thing, will be lifestyle and patients, which will be led by the patient. So it's important that the patient gets educated on this. When we are not able to control blood sugar very well with medicines, it becomes inevitable that we'll have, with diet, that is, and exercise, it becomes inevitable that we'll use medicines. And that is the reason why we now move to pharmacological management. So I'll take you through the medicines that we use for management of diabetes. So drugs used in the management of diabetes. The very first one is insulin. And we know this is because diabetes occurs when there's a problem with insulin, either secretion of insulin or resistance. In type 1 diabetes, the problem is that we are not able to make insulin, so insulin has to be given. In type 2 diabetes, the problems are twofold. On one hand, we have little insulin or less insulin being produced in the body, and we also have a problem with resistance. So for management of type 2 diabetes, we have to look at what is happening. Then we look at the points of intervention where we can provide medicines that will act in different ways to help the blood sugar to be normal. So we also have to know what happens after food intake. After digestion, the food is converted to glucose and it enters. Carbohydrates usually will enter the bloodstream as glucose. And of course, they'll go first to the liver. So at the different points where carbohydrates are handled, it is possible that we have interventions that will help us to reduce sugar. So the first group is the biguanides. And for biguanides, the one that we're using at the moment is metformin. We've had others like fenformin, which we are not using because they were phased out because of their toxicity. So we look at metformin in detail because according to our guidelines, it is the first drug that has to be used. So metformin will be the first drug we look at. We'll also look at sulfonylureas. We have 3 examples that we've given here. We have differences in the sulfonylureas, and it's good that we think about their duration of effect. We have had drugs that we are not using at the moment, like clopropramide, which have had very long durations of effect. And for that reason, they pose a risk of hypoglycemia. So we look at these drugs and we look at the next category, which is the meglitinides, where we have 2 examples, that is repaglinide and entaglinide. These ones are short-acting compared to the sulfonylureas. Then we look at thiazolidinediones, and in this case, we have 2 examples, that is pioglitazone and rosiglitazone. Thereafter, we look at the SGLT2 inhibitors, which act by increasing the loss of glucose from the kidneys, and then alpha glucosidase inhibitors that basically act in the GIT to reduce absorption of glucose after digestion. Then we look at incretin analogs. And after that, we look at the latest developments that help us that we can take advantage to ensure that we take care of our patients by looking at all the other conditions they may be having. So what are the objectives when you are treating a patient? We know that when there is diabetes, there's progressive decline of B cell function. So from the time a patient is diagnosed with diabetes, we expect the function to keep reducing. And the patients may have to use at some point insulin. So the goals for each patient will be to prevent or delay complications, and then to optimize the quality of life. So it means that for these patients, the intention will be different when you're treating them. You'll have to have a specific target for each patient based on their overall health. So you'll have to look at many other things. Do they have cardiovascular risk? Are they young? Are they very old? Are they at risk of a particular a problem with a particular side effect of a particular drug? So all these things have to be put in consideration when you're thinking about which drug to choose. So this is an oversimplification of the glycemic goals for the individuals. Sorry. So basically, we make a diagnosis of diabetes when the HbA1c is high. HbA1c is based on red blood cells. So it means we also need to look at the overall health of the patient if you are to take it seriously. If a patient has anemia, for example, because we are talking about red blood cells, it will be important that you take note of that. So this is a simplification. What you're saying is that for newly diagnosed and young, relatively healthy people, we have a lower target for the HbA1c. And for older patients with comorbidities who are also prone to hypoglycemia, we have a target that does not exceed 8. So when you're talking about treatment, as I have said before, the first drug that we'll be thinking about is metformin. It is highly effective and hence the cornerstone for oral treatment. So metformin majorly has its effects in the liver. And the 3 things that will happen, okay, a number of things that it will do in the liver. It will decrease hepatic glucose production. So it means there'll be gluconeogenesis reduced, and that is the liver will not be making more glucose, because what you want is a reduction in the circulating blood glucose. So if you are making more glucose, it means you are increasing blood sugar. So metformin will reduce hepatic glucose production and will also reduce breakdown of glycogen. It will again potentiate the action of insulin by stimulating uptake and utilization of glucose in the periphery. It also works to reduce intestinal glucose absorption. So you can check up the mechanism. It is something complex, but the fact that these drugs' effects are mainly in the liver make it a good drug to use because we are not pushing around the pancreas to secrete more insulin, and that allows the pancreas time to regenerate. Now, when you're giving metformin, you're supposed to start at a low dose. Basically, we should first establish your target, glycemic HbA1c target for a patient, and then start at a low dose. It's taken with food to reduce gastrointestinal side effects. Maximum dosage should be around 2 to 3 grams. Then it should be administered with food. It has a duration of action that is not very long. And what is very important is that it is wholly eliminated through the kidneys. So that is important because in a patient who has a renal function that is not good, you might have accumulation of metformin. So it is good that we use it having that in mind. So long-term use of metformin may be associated with B12 deficiency. So that is good that we have in mind. As I said, efficacy is high for metformin. It has a low risk for hypoglycemia. For the reasons we've just mentioned, it is weight neutral and the cost is low. So that makes it a drug that becomes easy to, that becomes like the best to use or the best to start with in our setting and also in other settings globally. What side effects are we likely to see with it? Gastrointestinal side effect like GI disturbance and anorexia. And then, as I had said a few minutes ago, we are supposed to use it with caution in patients who have a reduced renal function. And that is because of lactic acidosis, which is one of the side effects that we might have. Then in conditions like severe liver failure and controlled cardiac failure, it is good that we get other drugs which are actually better than metformin. So that is one drug which is the cornerstone, which every patient ideally should be on, and which is the drug that we give first before we give any other drug. Now, for the other drugs, it is good that we also understand how they work so that we know which drug we'll choose for a patient who has a particular kind of profile in terms of comorbidities. So the second category here is sulfonylureas. And basically, these ones act by increasing or causing release of insulin from the beta cells. So they increase beta cell sensitivity to glucose, allowing more glucose to be released. We've had many drugs, like I had mentioned clopropramide, which had very long durations of action. But nowadays we have drugs which have a shorter duration of action. Now, for these drugs, the worry we have with them is that the long duration of action may make the patients get hypoglycemia. So in as much as they're useful in helping the pancreas to release insulin, it is good that we check or we ensure we do not get problems with hypoglycemia. It also means when you're choosing it for your patients, you need to look at the patient category. If the patient is very old, if their eating is erratic, for example, it is good that we choose drugs that are appropriate for them. It does not mean the sulfonylureas are not to be used, because some people have now moved to these others. It just means we should be cautious and look at the profile of the patient and see which drugs are best for them. Adverse effects: hypoglycemia may be profound and long-lasting. Risk factors are increasing age, renal dysfunction. This is because if you have a problem with elimination, of course, there'll be accumulation of the drug. And then there's also a possibility of them causing weight gain. So for patients who are obese, it is good that we think of other drugs which may be better for them. Then we move to this other category of meglitinides, repaglinide and reteglinide. These ones stimulate insulin release. And what's important about them is that they have a very short duration of action. So they can be used just before a patient takes a meal. And the effects may be similar to those ones of sulfonylureas. Move to thiazolidinediones, which are actually insulin sensitizers. Now, these ones will act on the nuclear receptors to effect gene transcription. And so it takes a bit long for them to work, because they'll take longer to act by causing production of proteins that will help the body to increase uptake of glucose. So the actions again are basically in the periphery, and in as much as they'll take time, eventually they'll be useful because patients will be able to have insulin getting into the cell. So the effect is basically in the muscles, basically in the periphery. Side effects are limitation, and for this reason, it is good that we avoid them in heart failure. It also cause weight gain, and we have drugs which have been associated with risks of myocardial infarction, that is rosiglitazone. And for that reason, it may be good that we avoid these drugs in patients who have cardiac problems. Another category of drugs is the alpha glucosidase inhibitors, and we have two examples, that is acarbose and miglitol. Now, these ones will reduce or delay the absorption of carbohydrates by blocking the enzyme that causes breakdown of the carbohydrates to glucose. Dosing, they are to be taken the first bite of a meal, and then the dose increased slowly. The problem with them is that they will cause flatulence because you are reducing absorption of glucose. So there's accumulation of glucose in the gut. And that, of course, because of the bacteria that we have in the gut will cause flatulence and diarrhea. And for this reason, it's very unlikely that many patients may tolerate it. So basically, we may not see many patients on these kind of drugs. Then I'll talk about incretins. Now, this is an interesting phenomenon. Some people are doing experiments, giving glucose, the same amount of glucose orally, and giving it IV. And it was found that the amount of insulin that is produced on oral administration of insulin is greater than it is when you give it IV. So basically, with time, people realized there are hormones that are made in the GAT. Initially, it was called a gastrin inhibitory peptide, but the name was changed to GIP. So basically, these are hormones that are made. They have a very short half-life, and they help in they help in making the pancreas to secrete insulin. So this becomes another interesting point where you can intervene to improve the production of insulin. So they are released by the cells in the intestines usually, and they are rapidly degraded by the DPP4. Now, the DPP4 enzyme, which breaks them, provides another point where we can intervene to provide drugs that will increase the duration of effect of these drugs. So levels are usually diminished in type 2 diabetes. What are the actions of GLP? Number one, there is increased release of glucose. They reduce postprandial glucagon, hence they reduce hepatic glucose output, and then they also slow gastric emptying. And they promote satiety and inhibit the appetite. Now, these effects will lead now to a reduction in glucose, because when you slow gastric emptying, you reduce the rate at which glucose enters the body, and by increasing production of insulin, you are able to reduce the amount of glucose that is circulating. We have two analogs which are given by injection, which you can see here. Exenatide, which is injected before meals. We also have preparations that are given once weekly. Now, these drugs, to a very large extent, will resemble the GLP, a hormone that the body makes. And that provides another point at which we can make interventions. As you will see later, they have been found to be very useful for patients who also have cardiovascular diseases. And it's good that we think about that when you have those kind of patients. The only disadvantage is with cost, because as you see, anything that is made from proteins will not be as cheap as metformin and the others. Now I'll talk about DPP4 inhibitors. We've talked about GLP, and we said GLP is a hormone that is produced in the gut that potentiates the production of insulin. So because the half-life is very short, there is a way in which you can prolong its duration of effect by blocking the enzyme that breaks down this drug. So we have examples like vildagliptin and sitagliptin, which we see in our markets at the moment. And what they do is to block this enzyme that breaks down the GAT hormones. So by slowing down the degradation of the incretins, they potentiate that action, and we are able to have insulin being produced. The advantage is that, number one, they're taken orally compared to the other two we have seen. They're weight neutral, and they do not pose a risk of hyperglycemia. Now, this category, I can say, is a very important one, because in the recent past, we've seen developments and information coming out concerning how they can be useful in particular categories of patients. So SGLT2 inhibitors are drugs which block the sodium glucose cotransporter in the proximal tubules of the kidneys. And now this is the point where most of the glucose that is filtered is usually reabsorbed. So blood will go through the glomerulus, you have absorption, you have filtration, and then in the PCT, the proximal convoluted tubule, we have transporters that will absorb amino acids, glucose, and anything which the body needs before the contents of the lumen go down to the loop of Henle and thereafter to the distal, to the DCT. Now, at this point, if you block the transporter, the glucose transporter, effectively what you are doing is to prevent the absorption of glucose. And so glucose is lost in urine. What are the implications? Number one, you'll have an osmotic diuresis because the glucose in the lumen attracts water, and the sodium also attracts water. So you have effects that, number one, will reduce the blood. There'll be a diuretic effect because of that. And because you are increasing the amount of glucose in the bladder and in the urinary tract, there's a risk of having infections there. So that becomes the downside to it. But as we will see, these ones are a very important group of drugs that we should take advantage of at the moment. So if we are to start a patient on a drug, what will we be looking at? Now, if you are to look at our guidelines, we are supposed to start a patient on metformin. So first of all, it's good that we decide what the goals are, the glycemic goals for the patient. And then if you are to start a patient, we start them on metformin. So metformin becomes the first drug, then we will choose a drug and add to the regimen that will give the best benefit, that will give benefit to the patient based on the comorbidities the patients may be having. So we individualize the treatment. You start with metformin and add a drug with a different mechanism of action. And then you take into consideration things like adherence, changes in diet, and changes in physical activity. It's also good to think about other reasons for uncontrolled sugars. And this brings us to the point that it is good that at every time when we meet a patient who is diabetic, we get information about them and provide education and find out anything else they could be taking that could be making their sugars uncontrolled. So how do we go about treating a patient? As I had said, the first thing we look at is, first thing we'll start with is metformin. Then we look at the patient, the overall health of the patient. Do they have comorbidities? Are they at risk of cardiovascular diseases? Do they have obesity? And so on. Then you choose a drug that will be useful for that patient based on the other issues that they're having. For example, if somebody has renal dysfunction, it is with a GFR below 30, we are supposed to avoid metformin for the reasons we've already discussed, and sulfonylureas that have a long duration of effect because they'll accumulate and will put the patient at risk of hypoglycemia. For severe liver dysfunction, because most of the drugs are metabolized in the liver, you may want to choose something that will not really have an effect there, and so you will want to give insulin. In obesity, you don't want a drug which will worsen the obesity. So you may think of drugs which have a weight benefit, like the DPP-4 inhibitors and metformin. For heart failure, you should avoid the thiazolidinediones because of the effects we have seen with them. And what is now important and what is new information coming is that the SGLT2 inhibitors become useful in that category of patients. So basically what you're saying is that each patient, the choice for the drug should be individualized, should look at the overall health of the patient and make decisions that will be appropriate for that patient. So basically, I've talked about the drugs that we use, and I'll quickly talk about some updates that we've had in the recent past because of the trials that have shown specific benefit for some drugs. So it's good that we also take advantage of this for the good of our patients. So number one is SGLT2 inhibitors and GLP-1 agonists are now preferred in heart and kidney disease. They should be prescribed regardless of HbA1c or use of metformin. They're also shown to support the heart health in patients who are non-diabetic. So we have trials that maybe you'll take time and check up, like EMPA-REG, CANVAS, and DECLARE, which have been looking at these drugs. We start with EMPA-REG trial, where we are looking at empagliflozin, where the population of adults was 7,000, and we find that compared to placebo, we had a 14% reduction in total cardiovascular events, or 38% reduction in risk of heart-related death, and 32% reduction in overall death. Basically, what we are saying is that there is a lot of benefit for these drugs for patients who have heart disease. And for that reason now, with the new guidelines that we're having, we use them for patients who have diabetes and heart disease. And basically, even for heart disease, for a patient who is not diabetic. So this is another study where canagliflozin was used. Then we had the same thing, a reduction in, overall reduction in cardiovascular events. So this is something that you may want to use for patients who also have a heart condition, either heart failure or any other such condition. So the last one is this study where dapagliflozin is used for treatment of heart failure in people with and those without type 2 diabetes, and we also see a benefit here. So basically what we are saying is that SGLT2 inhibitors are drugs that we can now use basically for diabetic patients who have heart problems like heart failure or others. And we can also use them for patients with heart failure without, or with heart conditions without diabetes. So in a nutshell, what you're saying is, number one, when you're starting treatment, we should start with metformin. Number two, we should look at the patient's overall health. We look at the risks that they have. We'll then select a drug that is most appropriate for that patient. Thank you.
Thank you very, very much, Dr. Mwangi. That was really, really, really useful. Please stop sharing so that I can share my screen, please. Yes, thank you very much, Dr. Mwangi. I'm sure we've all been enthralled by your discussion, very insightful, and we've learned a thing or two. At this point, we will go into the question and answer session. And if we can have the questions coming, keep them coming, and we'll be able to read them one by one as you post them. So there's a question: has the essential medicines list of the Ministry of Health been revised to include the SGLT2 inhibitors? Dr. Mwangi?
Hello, hope you can hear me. I think the answer at the moment, I would say, is no. because it's something very recent and it takes time for the EML to be revised. But I'm sure the next time the revision is done, that will be factored in.
All right, thank you very much. Is there an interaction of antidiabetics and antihypertensives? When you talk about drug interactions, it will be good, or it is good to be specific about particular drugs because interactions act at different levels. It could be at the point of taking the drug orally, and most likely in this case, we'll think about elimination of the drugs. So to answer the question well, it is good that we get specific, and then we can look at each drug in specific and say whether there's an interaction or not. But generally, our patients who have diabetes will also present with hypertension. So for most of the patients, we'll have to use both drugs, both a drug for hypertension and a drug for diabetes. Now, both conditions, again, have complications that are similar. So you might find that there will be overlap when you're using those drugs. Thank you very much. There's a question about the drug rosiglitazone. It was phased out and not longer used. Can you say something about that?
Yes, rosiglitazone was phased out, and this is because of the information that came from studies that showed that it was putting patients at risk of cardiac problems. So at the moment, it may not be easy actually to get it. And what I can say is that because we have many options, it may not be a drug that we really have to use. Yeah.
Which antidiabetics interact with anti-TBs and ARVs?
Okay, when it comes to interaction, again, as I will say, it is good that to be specific. Now, generally, when you talk about anti-TBs, and anti-TBs, you said anti-TBs and
ARVs.
ARVs. Now, when you talk about anti-TBs, one of the major drugs that we use for TB is rifampicin. Rifampicin is a very potent enzyme inducer, which means it will induce the metabolism of drugs. So if you're giving it with other drugs, it means that the other drugs we may not have sufficient levels in blood for the therapeutic effect of those drugs to be seen. ARVs are different, and some of them are also enzyme inducers, like nevirapine, for example. But we also have a big population of drugs which are enzyme inhibitors, especially the protease inhibitors. Basically, a guide that you can have is you look at the mechanism of action of a drug. If a drug is inhibiting enzymes in bacteria, it is also likely to inhibit enzymes that are metabolizing drugs or the enzymes in the human being. So it is good that you become specific when you're mentioning these drugs, but there is that potential for interaction, either in them increasing the duration of effect of a drug by if they're inhibitors, or them reducing that if they are enzyme inducers.
Thank you. Emily, take over the...
Yeah, thank you, Doc, for that wonderful presentation. I will take over for the Q&A session here. So the next question is, are flucloxacillin and metronidazole empirical treatment for diabetes cellulitis in your setup? Is this from hospital antibiogram? Someone is asking.
Whether those drugs are useful
for empirical treatment for
empirical,
diabetes cellulitis in your setup.
Okay, in our setup, the drugs are used for infections, whether there is diabetes or not. Now, for this patient, if you had looked at, I don't know if we can go through the slide again, but you will see that there is evidence of an infection because there's a high WBC of 21. So that shows there is an infection, and for that reason, drugs are given. Now, when you're giving drugs, we look at the target microorganism. On the skin, most of the time, we'll be thinking about staphylococci. And so the choice will be a drug like flucloxacillin, which will be effective for that. Now, in cases where you have mixed infection, you are not sure whether you have an infection with a gram-positive or anaerobic organism, both drugs are used. But now, in our case, now to be specific about our hospital, the first thing is that we do not have an antibiogram, something that we are developing. And when we do that, and when we are able to have information about the kind of microorganisms we are having, it becomes better to choose one drug that is effective rather than have a mixture of antibiotics for any infection.
Okay, thank you for that. Another question is, which is the leading preferred choice for kidney dysfunction, diabetes mellitus for greater than 50 years, and most effective with a low side effect profile?
Okay, so for kidney issues, it is good that we stage the kidney dysfunction, and GFR is what you use for staging it. So regardless of the age, it is good that we look at the glomerular filtration rate, which indicates or which shows us how effective the kidney is in filtering drug. So we have seen drugs that have a short duration of action, like the azolidinedione. Sorry. So we'll choose drugs which have a short duration of action that will act within 2 to 3 hours, compared to those which have a very long duration of action, like the sulfonyl ureas. Then if the GFR is above 40 or 50, then we may not be really worried about most of the drugs that we're using.
Okay, Dr. Zainab actually says here, for people living with type 2 diabetes and CKD, the guideline now offers SGLT2s as a treatment option. And you just mentioned that in your presentation. So Dr. Joseph Murithi asks, kindly tell us about the role of medication therapy management in diabetes.
Thank you very much for that question.
Yeah.
Basically, what we said, or what I said again, is that we have a very large number of people who have diabetes and do not know about it. And even for the people who are taking drugs, we find that a very big proportion of them do not have their sugars controlled. This provides a very good opportunity for us to provide service to these people. And MTM now becomes one of the best points at which you can provide this kind of service. In our health institutions, especially in the public sector, even in the private, it becomes very hard for you to provide sufficient information to a patient at the point of dispensing. So what we are encouraging is that, or it's actually a challenge to every health professional wherever they are, that you start providing MTM services. Here you'll have a patient and you'll have time with them. You talk to the patient, find out what they know about the medicines, find out which medicines they're taking, find out if their sugar is controlled, find out if they have information about how their sugar, if they're keeping information about their sugar control. So this becomes a very important service that everyone can provide wherever they are. And I would encourage everyone, wherever they are, to start providing this service.
Yeah, thank you for that, Dr. So there's also another question. There's evidence that some patients, when put on a regimen, will continue taking the same drug for years without coming for a review. What new public health interventions would you recommend for the public to ensure they are getting proper care and they know what their responsibilities are in the management of their diabetes?
Public health interventions, basically, mine will be to encourage the health professionals to provide public education. Now, as we said, most of the people do not have an idea about do not know much about diabetes. If you're able to reach them, I think that will provide a good way to allow these people to get the diagnosis done early so that they are able to be treated in good time.
Okay, thank you for that. I think I'll take one last more question. Dolutegravir has been associated with higher rate of hyperglycemia. Any considerations on HIV positive patients? Doc, can you hear me?
Yes.
Dolutegravir has been associated with a higher rate of hyperglycemia. So any special considerations on HIV positive patients that you'd like to comment on?
Basically, okay, I wouldn't say much about this, but I feel for a drug that, okay, for dolutegravir specifically, we are seeing we are phasing out other drugs and putting those patients on dolutegravir. It's still possible that for a number of patients who are able to take other drugs, that dolutegravir can be replaced with other drugs. But maybe somebody else can help with this information. Maybe, yeah.
Okay, I think we can have a further discussion on that and by the side to have a clarification on that issue, and then we can get back to our participants with the right answer. Okay, another question is it recommended for diabetic patients on medication that they can also combine supplements such as chromium or alpha lipoic acid? What's your view on that?
Okay, concerning supplements, I think supplements are another world altogether. Basically, when there is diabetes, we think about sugar and how to control it. I may not say there are supplements that may be useful or not useful. I think it's for somebody to decide whether to give them or not. But we cannot say that either supplements will be more effective or will not be effective for a patient. So I think to me, it is a neutral thing. But that's your personal view, yes.
Okay. All right. Thank you for answering, taking the questions and giving us your feedback.